Now I call upon Dr. Murali Kaushik for another important topic, that is risk factors in childhood progressive myopia.
Grateful to AIOS for inviting me to be a part of this national symposium. What I hope to walk you through is what are the possible factors that we need to consider when you're looking at myopia progressing as a risk. Is it important? Of course it is. Dr. Praveen has showed what the data is from across the world, and the data even from India does not look that great. Why does it matter, or why do we want to slow down progression? We know that when the myopia progresses, there are chances of other ophthalmic complications resulting in these children, as well as we know that we need to intervene early because the strongest progression is noticed in early childhood. So we know that they would stabilize eventually by the time they're about 21 years of age. So unless we act fast and we identify those at risk, then there is a problem. The first question is, are we triggering or are we risking children progressing by giving them appropriate correction? So there is a tendency to undercorrect, and the first risk that we need to remember is not a risk, is actually undercorrecting these children. Undercorrection actually results in educational delays. It can risk bullying or even ostracism in terms of their daily schooling. So unless there is a very, very clear indication, which definitely is not a risk of myopia progression, you should not use undercorrection as your first strategy. So that's again very, very important. However, the risk of progression starts off from the way our clinics are designed. So a lot of us, because of constraints of space, may be working in refraction lanes that are shorter than 10 feet. And there you need to remember that the charts today, the digital charts, can be modified or calibrated for distance that allows you to measure visual acuity, but that does not take away the possible accommodation that may happen. So first thing I would recommend everyone to do is take an inch tape, measure out the length of your refraction lane. If it is less than 10 feet, it's very simple for you to calculate. Figure out how much you need to undercorrect every refraction that you're doing. That could possibly be one of the risks that is in our control completely to handle it. The next we looked at is, does it matter how high the chart is put? So again, that does not seem to be a risk factor for us to overestimate the myopia in children attending our clinics. So we did not find too much of a difference in terms of the height. Most of us prescribe monovision glasses. The fear again is, are we risking progression by doing that? Should we actually give a bifocal that was tendered? If you look at the video that's playing on top, this is a girl who's been given a bifocal. And what you will notice is, as she keeps reading, she doesn't look through the lower part, but actually lifts up the book to see from the upper part. So the little picture on the side shows what magnification you would see with the near ad. So don't worry, you're not risking progression or you're not causing progression by giving a simple monovision glass, because children invariably will not look through the plus segment, because for them there is no improvement that they see or no benefit that they see. The next part of it is, where do we live? That seems to be a big factor in terms of myopia progression rates. So studies from across the world, unfortunately, the more eastward you go, the rate of progression seems to be much higher. Surprisingly, we're seeing these trends catch up even in the Western world, so to speak. But in the Western world, where there's a mixed population, again, ethnicity seems to play a role. We as Asians living in the East seem to be facing a double whammy of where we are located. So ethnicity plays a key role in terms of in terms of being a risk for progression. The Chinese population in Australia have been shown to have a lower rate of progression compared to the Chinese population living in Singapore. So there seems to be a play of nature as well as nurture in terms of what happens. Again, a recent article that was published in China. Again, we don't have data like Dr. Praveen mentioned in India. We don't know what the difference in progression is in various ethnic groups in India itself. In China itself, they've shown that the progression rates have a difference of almost 20% between various ethnicities in one small district of China. So it's left to our imagination as to what it could be. Some risks are gender dependent too. Again, there is a study by SAW that said that it didn't matter in Singapore, but a majority of studies from, again, across the world have shown that women or female children seem to have a faster rate of progression compared to men. So we do anecdotally see this within India too, but again, there is not enough data possibly collated from across the country for us to arrive at those conclusions. Again, sticking to genetics, These are again things not under our control. The gender you're born into is not under your control. Parental refraction has again been reported to be related to myopia. The odds increase if both parents are myopic, and odds increase with the level of myopia among these parents also having it. This again makes it very, very important for us to get into the family history and find out, because a large number of young parents will walk into our clinic without glasses because they've possibly had a refractive surgical correction. So it's important to find out whether they've ever worn glasses in the past or whether they've even had an eye test. I've had surprises where parents are -2, -3 myopic and just carried on with their life. They don't seem to, it never mattered to them to get their eyes tested. So again, this is a small data set from our own population where we looked at about 100 children, and in those who were rapidly progressing, we found the parental myopia incidence to be much, much higher in them. So again, in children who are progressing higher, or you know that if both the parents are myopic and you put the child on glasses when they're much younger, the possibility of them progressing becomes high, and we need to see how closely we can follow them up. Now that we've done with the nature part, let's look at other factors that are under control. Educational level has been shown again across the world in terms of being a risk for progression. The possible mechanism is accommodation, the way they hold it, and the lack of aberrations that seems to play a role in those who are reading longer hours. Exposure to schooling rather than the age, again, has been shown to be a risk factor. Peculiar cram schools, we do see them across our country too, where children spend very long hours at the school, very little time outdoors. These have been shown to have a very high risk, and there is almost a phenomenally higher chance that these children may be myopic. Again, we are not clear whether it is because of the children spending more time reading or less time outdoors. What that interplay is, that nobody seems to know. But what we do know is higher light intensities and variations between indoor and outdoor time. The more time children spend outdoors, and some countries have even brought in rules to mandate that children should spend time outdoors, that seems to again play a role. Outdoor time, 40 to 80 minutes, reduces onset of childhood myopia. So inversely, children who are more indoors seem to be having a higher risk of progression. So if a child is an introvert, if they've been bullied, it's very unlikely that they're going to spend time outdoors. So it's good to talk to them, find out whether they have friends, what their daily hobbies are, how we can encourage them to spend more time outdoors. Seasonal variation, again, has been shown in North American school children. Mechanism is possibly thought to be due to the lower exposure of natural daytime in winters. But again, fortunately for us in our country, we are blessed with good sunlight pretty much through the year, except for small pockets. So this may not matter so much in the Indian scenario. Does the room light cause a risk? Again, there is data among animal studies to say that brighter the light intensity, lower the kind of risk of progression. So children who read in low light situations possibly again are at a higher risk of progression. And indoor lighting, we know, is almost about 1/10 of what the outdoor lighting typically is. There again have been theories about using light, red and blue, green light, to slow it down. So we again looked at it saying that does it even matter? We did not find too much of a difference in terms of the binocular vision parameters, but the accommodative facility seemed to improve with red and green light. So they were able to read better, but we didn't find any obvious risk that is there. Even with the amount of brightness of light, again, there are studies that show that it matters. Our traditional Gurukul system, where we were outdoors and bright light, possibly made sense. COVID was a big risk. Again, it is attributed to children possibly spending more time indoors than the use of digital devices. Again, we have our own data to show that children who spend more than 2 hours and were on low-dose atropine had a much slower rate of progression compared to others. So we need to see how that can be added on. One other risk factor that we are getting seen reported from across the world is the level of vitamin D3. So this again seems to play a role in multiple forms in causing the myopia to progress faster, and it is again important for us to recommend screening for vitamin D3 in children once in 6 months, and if it is low, to correct it to slow down the rate of progression. One tool we love to blame are digital devices. Again, we feel that children more than 3 hours are at a higher risk. This could be because of accommodative demand. The blue light from these devices has been blamed. The dim lighting from the dilated pupil has been blamed. And then if the children are happy indoors, they're unlikely to spend time outdoors. So this has been taught to see. We looked at changing the brightness of the screen, and we found that the dimmer the screen, children tend to keep their screens at a dim light because they can hold it much closer and the battery lasts longer. But the minute you increase the brightness, they seem to pull it away. Again, parents walk into our clinic saying, my child lies down and reads. That's why the progression has happened. So we looked at saying that's posture attribute to be a risk. So we built a VR-based solution where you can simulate a kind of a reading chart, and we looked at accommodation and convergence in various postures that the image shows. And to our surprise, we found both the NPA and NPC not change irrespective of position. So obviously, posture is not a risk for myopia progression, but the distance that the child holds a book when they're lying down is possibly a risk. This is the last slide where again there's this very strong correlation noted with parental myopia, education, a moderate correlation with near work, that again is a very strong relationship or an inverse relationship. If children don't spend time outdoors, the risk of myopia is very high. Light exposure is moderate. Environment has been shown to be very weak, and digital screen again has been shown to be very weak. So I hope that this kind of gets you thinking as to what risks are there in the children who come into our clinic.